said, I'm the off-the-shelf clinical manager here at UCSF and the Orthotics and Prosthetics Clinic. And today I'm going to talk about the role of athletic trainers in your clinical practice in O&P and how that can be beneficial to you, and how our expertise can assist in your clinics and not only provide an extension of care and an extra care that you may not be able to provide currently, but also a business model that is proven to be very effective and cost effective in a lot of ways with O&P. So to start, I have no disclosures. This is just something I created. And just talk about what we're going to go over today. So our overview is, first off, I'm going to tell you what an athletic trainer is. A lot of people have a misconception of who we are. They hear trainer and they automatically think the people in the gym that are telling you how many sets and reps to do something, in which I'll show you that our education is far beyond that. So that's first off. We'll go into the history of this clinical design, how we ended up with athletic trainers in O&P, as this is not a practice you'll see across the U.S. It's actually very new. It's considered an emerging practice for us. And so I'll discuss how we got here. I'll talk about how it's evolved over the last 8 years that I've been at UCSF and, where we're at currently, and then some future ideas and thoughts that we may be able to explore that we haven't gotten into yet, like I said, because of how new we are in this field. But I think there's a lot of opportunity for growth for us to continue to do what we do and do other things as well to help O&P. So first off, what is an athletic trainer? This depiction right here gives you the best idea of what you'll see at what we call a traditional setting. So if you've watched any sporting event on TV or in high school's football, college, anything like that, when somebody gets injured on the field, that first person out to them is almost always an athletic trainer. We're actually allied healthcare professionals that treat a multitude of injuries and issues in many ways. The long definition is here on the left. You can kind of read through that on your own time, but what it's saying is we're allied healthcare professionals that work work in collaboration with a physician to handle a multitude of different pillars of healthcare, including illness prevention, injury and illness prevention, wellness promotion, education, emergency care, examination, and clinical diagnosis, as well as therapeutic intervention and rehabilitation of injuries and medical conditions. We have a multitude of skill sets. We're kind of a Swiss Army knife of medicine, in the sense of we're one of the few professions that can go from beginning to end, so pre-injury to post-injury to rehab to back to sport or activity or work, whatever we may be working with at the time. We are educated with modality use, so we can use a multitude of modalities as far as how to treat an injury and rehab it. We're experts in concussion management. It's one of the strong suits of athletic trainers. We really focus on stage 3, 4 rehab out of the stages 1 through 4. 3 and 4 are really our specialty, in the sense of how do we get people back to more than just ADLs. We don't want people to just be activity of daily living. In our traditional setting, we're trying to get athletes back to their sport and to be back at that high level in their sport. In other settings, we may just be getting you back to being able to do your job well, which may include construction or heavy lifting movements, things like that. We know wound care and management. We're in a multitude of settings. And in our undergrad education and our master's education, we do get a basic brace training for mostly off-the-shelf DME in splinting. We do casting and splinting of different sorts that we're educated on in our undergrad. Our education is actually pretty extensive. Currently, the way the program works is you can go to a 4-year undergraduate CADE accredited program. You do 800 hours of clinical time and observation working in either a sports clinic or a physical therapy clinic, a doctor's office. There's different settings we can be in. At that point, we can sit for a BOC board exam. Depending on the state, there's different levels of certification. It can be anywhere from just a basic certification, is what it's called, all the way up to a licensure. Just depends on the state and what that state regulates, but it is different state to state. Most, about 65%, go on to a master's program 2 years post undergraduate to get their master's degree in athletic training. It's just become more of a standard of care at this point as far as education within our field. In 2020, the education is actually going to be changing over where you will still go to a 4-year undergraduate, do your 800 hours of clinical time, but you're going to go to a mandatory 2-year post-bachelor's program to get your master's in AT. And it's not until you have your master's that you'll actually be eligible to sit for board exams. So if you do end up using athletic trainers in your clinic and you're going to be hiring in the future, just know that they won't be eligible for hire right out of undergrad to be a certified athletic trainer or a licensed athletic trainer. They'll actually have to go to a 2-year postgraduate. So it is 6 years of sports medicine that we are learning and being educated on, and about 1,500 total hours probably by the time it's all said and done of observation of clinical time. So we get in there, when we come out of our master's program, we're pretty well versed in what we do and how we do it. We're in a lot of different settings. So traditional settings are considered college and secondary schools, high schools. 17% are in clinic and hospitals in different ways. The large majority is still students. We're a rising profession. I mean, we've been around for a long time, but in profession age, we're still, young. We're in toddler years. We've really only been present in probably the last 60 years in sports and other activities. 2% are in professional sports, and 2% are in emerging settings, which is what we call this for orthotics and prosthetics. I recently did a talk at our National Assembly on athletic trainers and O&P as an emerging setting. So we are getting into different settings where they're learning to utilize our education and medical background to do a multitude of different things and really work on making whatever it is that we're in be better functioning with health and rehab and everything else to get people back to doing what they need to do, whether it's their job or performing arts, public safety. We're in the military, we're in occupational health at this point. So this is really an emerging setting that we're trying to expose and get more exposure to, hopefully, and really give athletic trainers a new avenue of job opportunity. So the history of our clinical design, why this is important, is how athletic trainers, at least here at UCSF, ended up in O&P, where this was really a new idea. When I got out of undergrad at San Jose State, I was just looking for a job. This program here at UCSF called PlaySafe was hiring. PlaySafe does something where to provide a full-time, 1 FTE position, they partner with local high schools to provide partial coverage to the high school, and then the hospital gets you for the other time. And what that allows is an athletic trainer to get a full-time job where most high schools can't afford a full-time athletic trainer, nor do they need a full-time athletic trainer. And the hospital can benefit from using us in many different ways. We're in all different clinics here at UCSF, from working in hand and foot with casting and rooming, as well as in like our sports clinics and our arthroplasty clinics as physician assistants, pretty much doing rooming and evaluation, teaching rehab. So PlaySafe has this program where we actually have, I think, 16 athletic trainers currently on staff here at UCSF, working both in clinic and then outsourcing to local high schools. And like I said, this allows you to split up salary. And so even if you at your hospital or clinic or private practice don't have the funds to really support a full-time athletic trainer, there's other options. So I came into that program at PlaySafe, splitting my time between orthotics and prosthetics and local outreach. Well, what we learned after a year or two is that there was a real benefit to me being in orthotics and prosthetics as far as what I was able to deliver and help with and assist with. So from there, we created, when I came in 2011, was to really help create what was called this ACT program, this Amputee Comprehensive Training. And what we wanted to do is take athletic trainers and use their knowledge in stage 3, 4 rehab to help get amputees back more than just ADLs. When they're able to accomplish their ADLs in physical therapy, likely insurance won't pay for it anymore. And there really isn't much of a bridge to take a patient from, okay, I can walk and, go to the bathroom and, garden a little bit and get around my house or get to my job and get home, but I can't do anything else. Nobody's taught me or helped me get to that next level of doing any other activity to maintain health. And so that was a big part of bringing the athletic trainers in here, was that program and how we wanted to handle that and set that up. And then the other side of it was the business side, and that was more handling all of our off-the-shelf services. So by bringing in an athletic trainer, and it took a lot of our off-the-shelf responsibilities off of our CPOs and our COs and our CPs and allowed them to do what they do, and the athletic trainers handled off the shelf. And it separated those two entities in a positive way to where, you know, ATs kind of had control and real ownership of that position. Every athletic trainer that comes into here completes a CFO course to become a certified fitter for billing purposes through ABC. So they only need 500 hours of observation as athletic trainers, being recognized as allied healthcare professionals. We don't need the 1,000 hours of training that ABC requires if you aren't a healthcare professional. So we only need 500 hours of observation, and then we can go to our CFO course and then sit for our exam. The positive is the large majority of what the CFO course is going to test on athletic trainers are already very competent in, as far as anatomy, injury management, injury recognition. Mainly it's learning what brace is going to go with those types of injuries. And so the learning curve is super small and very short as far as getting an athletic trainer comfortable in clinic and getting them fitting patients and doing what they need to do. It takes about 12 and a half weeks in a 40-hour work week to hit that 500-hour mark. So it's not difficult. And like I said, it's a very short learning curve to get athletic trainers really functioning in your clinic, even if they aren't familiar with orthotics and prosthetics. When our athletic trainers came in as well, and what I did is I created what was called a FAST program for our ACT clinic, and this was focused amputee strength training. So again, this is at stage 3-4 that we're really looking to take athletes and actually everyday people to. You know, one of the biggest requests I got from amputees when I first started the FAST program is dancing. They wanted to go dancing with their significant other, and they really struggled to be able to do that because if they went grocery shopping, they were winded or exhausted from the energy expenditure. And so it's not just a sports program, you know, it's a strength training for higher level function, not just sports or sport activity. It's really just for daily life activity of doing what people want to do outside of walking. And so we worked on creating this FAST program to put into our ACT model to really get things going with that. Also, athletic trainers, you know, we're good with our hands. A lot of times we work in underprivileged areas and we have to be very creative. So we know how to use tools. We know how to create things. We know how to modify things pretty well coming out of school. And so when I was first hired, I assisted with a lot of our technician duties as we didn't have a technician here at the time. So I learned how to pour a socket, break out a socket, grind it, and really have it ready for as a test socket and ready to go. So I was able to take some of those duties off of our clinicians as well until we had a technician here. But learning those things also allowed me to learn how prostheses work, you know, what causes what, why you need this, how they load this, how they activate that. And so working in the technical side of things with that really allowed me to become so much more educated on how everything works and what I'm really trying to assist with within these FAST programs and why there's certain deficiency and why there's certain energy expenditures that we want to reduce. So that was another thing that I was able to give back to. And then we manage a lot of our shipping and receiving. So if we're handling our OTS, which is going to have your highest turnover, a lot of your ordering and replacement. Again, it was another service we took off of someone else and allowed them to do their job while we handled a lot of the actual materials and management of those things. And as we continue to do things and see the benefits of it, these clinics evolved and our role as athletic trainers within the clinics evolved. So from the basic ACT format, which was mainly held in a human performance center, we would dot somebody up and see the 3D model of their gait. We would do an evaluation with physical therapists to see where their deficiencies and muscles were, and then the athletic trainers would kind of teach that stage 3-4 rehab. We came up with other ideas where we could, you know, integrate people into different activities and get them involved and get them more active and healthier. So we did fall clinics, which I think was a super important one. I actually took it from jiu-jitsu that I did, where they teach you how to fall appropriately and teach amputees how to fall so they weren't coming back with wrist injuries and head injuries and shoulder injuries. We did yoga, which was a lot of fun, rock climbing, general rehab. And so we were able to find a lot of different things, cycling, that patients were interested in and really wanted to do. And we adjusted those ACT clinics and our FAST clinics to kind of accommodate for those activities on how do we get those done and how can we do those in a prosthesis. From there, we ended up hiring multiple ATs for different roles. So each AT kind of takes on a different persona within the clinic. I manage all of our off-the-shelf as far as between all our locations. We have 3 currently and likely expanding. So I handle, what people stock, what they keep. By keeping everybody on the same page, it reduces costs, it reduces ordering issues because it's the same things over and over at all the different clinics. And then I manage our ATs that work within those different clinics. We created a physician-patient liaison role, so the athletic trainer would fit braces, but also work with our physicians on things like documentation to make sure they're meeting Medicare standards, talking with patients in clinic to set up expectations as far as knowing what their cost and insurance coverage was, educating the patient on what a brace was before they came down to see us to understand that we're not a CVS, we're not a Walgreens. You don't walk in, pick it up at the front desk and walk out. We're going to fit you. We're clinicians here. We take care of you. We educate you. We adjust things. We modify things. And so by managing physician and patient expectations through this liaison service, we were able to create a really cohesive workflow between multiple practices. And we were able to get those practices all on the same page with us to manage patient expectation, which led to a higher likely to return and patient satisfaction for both the physician and for O&P. And by doing all those things, that increases your overall referral numbers because everyone's happy, so they keep sending more and more to you as they get busier and busier. We created for both inpatient and outpatient. So at UCSF, we do have an inpatient service at Parnassus where, again, the large majority of the braces that need to be fit for inpatient are off the shelf, T-scopes, cam boots, PFS boots, things of that nature. You don't need a CO or a CPO taking their time out of the day to walk over to the hospital to fit and educate and get back. Their time would be better spent modifying or casting or evaluating a new custom patient that needs something beyond that off the shelf. And so we were able to build a better, a more cohesive relationship in the hospital where it's a similar person going over and over to that hospital. It's a familiar face, and familiarity creates a very positive workflow. And so we're working both inpatient and outpatient currently with our athletic trainers and off-the-shelf bracing. And then we're able to expand our clinics being serviced. So by separating this OTS and this custom, we're able to focus on different clinics that have off-the-shelf needs, like OBG for wrist splints and mothers-to-be, or all different kinds. And so giving the time for the athletic trainers to go out and find these other clinics, educate on our services, and inform other clinics that we're here and what we do and what we have to offer and what we can offer, it allows us to increase our overall workflow and increase our referral numbers from different services. And again, by doing that, you create a better experience for the patient to be seen in one place and then get what they need and get out, rather than having to refer out to other clinics and do things of that nature. So we're continuing to expand those roles, or that evolution hasn't stopped, mainly because likely our locations aren't going to stop and our patient numbers aren't going to stop. So the opportunities are really kind of endless to how ATs can be utilized in many different ways with this off-the-shelf format. It also created a hierarchy and created a whole new kind of business format. So, by doing this, we actually created a managerial position so that these locations needed to be managed by one person and create that hierarchy. We also, because of our education and what we do in undergrad, we're experts on SOAP notes and documentation already, because in undergrad and grad school, we're taught to document like doctors. We're taught to document like MDs do, in the sense of if you don't document it, it didn't happen. And if it didn't happen, you're running the risk of, things coming back to you. So we're very educated in SOAP notes, which allows us to keep up with like CMS and Medicare standards. I'm actually our Medicare liaison and expert in our O&P department. And I go to conferences annually. And again, because I speak the language, because I was educated on what they're looking for, because I know what doctors are documenting and how they're documenting, I'm able to keep up to date on these different Medicare standards year in and year out as they change and become more difficult. And by doing that, I'm reducing our risk of audit and audit issues, because I know what's happening, I know what's going on. It also gives our other clinicians a point of contact to go to with questions when they're not sure about something. A lot of times I have the answer, can find the answer for them when it comes to Medicare and Medicare standards. We can work on quality control and standards of procedure, so SOPs. And what I mean by that is, if everybody's doing the same thing, if you can streamline how you work these workflows and how you work with off the shelf, you create a built-in quality control, and it allows you to really kind of self-audit yourself, so you know where you're lacking and where you're succeeding, but then at the same time correct those things so that everybody's doing the same thing. We may have 3 different clinics with all different clinicians doing all different things, but we can control that workflow for at least off the shelf, because the athletic trainers in those clinics are educating everybody. We do it by XYZ, 1, 2, 3 step, and you follow those steps appropriately. And by doing that, you're really allowing for a better workflow, and again, a less risk of having things like audits come back to get you. We're experts in electronic medical records for off-the-shelf and rehab documentation. Again, because of our prior education and what we're looking to do, it allows us to know what insurance is and what Medicare is looking for in documentation. So not only from what we need from the MDs, but also in our practice and our clinic, and we can get every clinician on that same page if they happen to see off-the-shelf. And then we can keep up to date on new and emerging off-the-shelf devices. Prosthetists and orthotists don't want to go to conferences or AOPA or COPA or any of these conferences and really learn about off-the-shelf bracing. It's not what their passion is and not what they went to school for, and it's not what their main concern is. So by allowing the athletic trainers to kind of hone in on this role and take it over, you're allowing us to stay the most up to date on what's out there and what's new. And it keeps our clinics the most up to date. So, we're not falling behind on just using the same old brace over and over when there's something better out there for off the shelf. And so we can attend those conferences. That's our main focus. That's our only focus. And it really allows us to stay up to date on what's happening. With what we're doing now, we kind of have this hierarchy of positions of what we're doing at UCSF. And this is a model I think a lot of clinics can emulate in a lot of ways. So we have our manager that manages the athletic trainers and the locations, oversees all of our off-the-shelf workflow, keeps everybody on the same page in the same workflows. For us, we're on Epic, and we happen to update we did a peak performance review and updated all of our note templates and things like that. And as our clinical manager, I was able to design all of our off-the-shelf templates that I know meet all of Medicare standards. And if everybody's documenting on those templates, that means not only for Medicare, but for customary as well, or Medi-Cal, we're going to hit all those bullet points that we need to hit in our documentation, and everybody's going to. So no matter who's covering clinic, they know they can choose an off-the-shelf template, and they're going to hit, as long as they fill that template out, they're going to hit everything they need to hit and the most important things. And so, that's how we have that going. We do have a physician and patient liaison position where we have a floating AT in our referring clinics, talking with the doctors, talking with the patients, managing expectations, really educating on the biggest one is insurance info, what their copays are going to be, what their options are with those types of things. I've learned in my 8 years here that if you can manage a patient's expectations, especially on cost, people are willing to pay for good service, but they need to know about it ahead of time. It's when patients get bills on the back end that they had no idea about that they're upset. Same thing with physicians. They're getting those phone calls from those patients upset that they prescribed this brace. So if we can manage those things and do that, we've really seen a really positive impact from both the patient satisfaction and physician satisfaction in our clinics, which again, like I said, has increased our patient referral. We have our inpatient, outpatient care at Parnassus with athletic trainers over there handling that, where they do the large majority of our inpatient delivery and education. There's a lot of nurse turnover in hospitals that you'll see and things like that. And so our athletic trainers can educate as well as deliver DME and bracing over there while still handling an outpatient care clinic. We lead the FAST clinics in the amputee comprehensive training model. So we're working on that stage 3-4 rehab to get amputees back to a higher level, as wars have happened in the last, 10, 15 years, as well as the issues like the bombings and marathons and things like that. We have a very active amputee population coming out with not a lot of direction or availability or options to really better themselves other than adjust on what they know. So we're really working on developing that FAST program and that ACT model to just become a standard of practice. And when you're seeing here you're evaluated, you're fit with your prosthesis, and then an athletic trainer comes in and evaluates and does their part and gets you going back to a higher level of activity. We participate in a lot of committees here as well as for the athletic trainers. So we've developed a quality control committee that the athletic trainers run to allow us to, again, attend these CMS events to know what the most up-to-date need things are from Medicare and documentation. We work on outreach as well, where we can look to donate and do other things with maybe local high schools and things like that on education or provide service. We want to provide rehab within the clinic itself. So, we want this to be part of our everyday service that we provide to our amputees to really do that extra step. It's that one extra thing that maybe they can't find somewhere else. We also handle all of our stock and vendor leads. And so the nice thing is when all these vendors are coming in with all their new products and everything they want to show you, they're not going to take up the CPOs and the CPs times talking about an off-the-shelf brace that, again, they don't want to participate with. They don't want to have to deal with those things. They don't want to fit those braces. They want to make custom things. They want to do the things that they went to school for. And so we can take that off their plates and put it on ours and really allow us to handle and manage that in a much more streamlined way. And then we're looking at research as well. In O&P in general, research is probably one of the most lacking things that we have. And so we're always looking to expand upon that. And this FAST clinic is actually a future endeavor for research where can we document and show that through exercise, these certain exercises or these consistent issues we're having with prosthetic patients, can we correct them? Can we make them better? And how can we do that? And with our Human Performance Center here, we're able to analyze things like gait or metabolic rate or muscle activation. And so we're working on a research side of things as well to just validate more of what O&P does and why we do it, and then validate this model of care so that, we can maybe get insurances to pay for it, so that there's things in the future that we can do to make it a standard of care, not just a model of care that people are hearing about. The effects that the ATs have had in clinic have been huge here at UCSF. Mainly you can tell that by the expansion that's continued to happen. We have in O&P alone, we have 4 athletic trainers currently with another position open and likely more hires to come in the near future. And it's because of the value we've been able to bring to clinic in different ways. One, our CROs and our CPOs are able to increase their patient numbers, which they have over the last 8 years since I've been here and as we've added athletic trainers, because they're not taking the time to see off-the-shelf patients. They can schedule more initial evaluations, follow-ups, fittings, and everything else. Taking that off of their plate has increased their ability to see patients exponentially. It's increased new patient evaluation. So that's usually what takes the longest for any clinician is a new patient evaluation. And by taking those little 15-minute blocks off their schedule to fit a wrist brace, a cam boot, T-scope, they're able to add new patient evaluations, which gives you patient care. And usually these are long-time or lifetime patients. And so it gives you people that, are going to continue to come back and need things and adjust. And it allows you to keep that consistent billing flow going. We found a quicker turnaround times for fittings of appointments as well with our COs and CPOs. Again, because they're not handling off the shelf, it gives them more time to modify their braces, pull their sockets, pull their AFOs and things of that nature. So by decreasing their time with OTS, they're increasing their time to do documentation and fabrication. And so that's leading to quicker turnaround times, higher patient satisfaction, and happier clinicians as well. We're all here to serve patients and do the best we can to make them as happy and functional as possible as soon as possible. So the more we can do that, the more everyone's happier. We assist with wound care when needed as well, because we are educated in wound care. A lot of the patients, you're doing skin checks, you may have injuries from falls and things of that nature. So within clinic, we can help assist and handle wound care to take care of those things. So again, it doesn't have to be referred out, or you may have to delay your care because of it. We can help assist with that. And again, give that patient what they need quicker and faster by being able to handle things within our own clinic rather than refer out or wait on other things to happen. Like I said, our patient satisfaction has increased with our amputees due to the extra care they're getting. These FAST clinics, these ACT clinics put smiles on a lot of people's faces for a lot of different reasons, whether it's seeing other amputees because you've never seen one, or you've increased something in your own actual daily life that you weren't able to do before. spouses have been a lot happier too. You know, that a lot of times with amputation or orthotic needs, it's not just the person that's getting the device that's affected by this, it's their significant other as well. And so the better quality of life you can give that amputee or the patient with orthotic needs, the happier their home life tends to be as well. And we get a lot of thank yous from spouses saying, you know, doing this or assisting with this has helped increase our life together. It's not just one person that you tend to affect, which is an amazing feeling. We assist with the technician needs when needed. So again, that leads to quicker turnaround times where if they're seeing patients and the off-the-shelf clinic is slow, to still be, you know, positive, adding positivity to the clinic, we can do technician needs and increase, you know, turnaround time or fitting or whatever it may be. Our reimbursement is increased, again, because our documentation's on point, it's streamlined, it's consistent, and it's within Medicare standards. We have very little issues with audits and payment pulls. And it's because we've been able to create these templates, like I said, and these workflows and these SOPs that everybody follows. And by everyone being consistent and everyone being on the same page, so everybody may do something a little differently, we're hitting all the same points. We're increasing our reimbursement rates, in which obviously we know we need reimbursement to stay alive and to continue to operate as a clinic. So we're really taking our time to make sure that that is on point to increase that. And then we decrease our audit. You know, Medicare likes to concentrate on people that they know continually make errors. And if they're continually auditing you and not finding anything, they tend to concentrate a little less on you. And so we haven't had to worry about audits as much with that kind of stuff as we do internal audits, and we check those things ahead of time so that we know we're on point. And it just decreases our overall stress with CMS. And then what we really did is we created two different business models here. We have two separate entities at UCSF, where we have an off-the-shelf entity and we have a custom entity, because they're two different beasts. They're two different workflows. They're two different mindsets. And so by separating the two and giving one to the athletic trainers and one to the COs and CPOs and CPs, you're creating this workflow of really concentrating and specializing yourself on what you went to school for and what you know and what you're educated on, and who's the most and up-to-date educated. And so we're really creating a separation between the two to create continuity. And it's really shown super positive effects within our business operations and the way we do things in our bottom lines, because people are focusing on what they need to focus on, and they're not scattered and separated in all these different directions. And what can we do in the future? So again, because of our education, it really increases our abilities to do a lot of different things. We're going to continue to expand the roles of the athletic trainers as orthotic fitters. You can work on therapeutic shoes. You can have mastectomy fitters. And you can even work on CPED, looking at certified podorthists to do custom orthotics and diabetic shoes. We only need 1,000 hours of observation, but because of our undergrad education, we're able to do a lot of these things without a lot of extra education. We've already done all of it in undergrad, where we meet ABC's needs to sit for these board exams. It's mainly just observation hours within the clinics discussing what they are and what's going on. So it's really a positive thing that we can expand our role quickly. Again, the learning curve is very short due to our undergraduate and graduate education. We're looking in now currently to look at O&P assistants or technicians, so certified orthotic assistants, prosthetic assistants, and prosthetic and orthotic assistants. Again, the only thing we really need is some observation hours and to sit for the board exam. So it allows us to bill for, I think, a lot of the smaller things that we tend to miss. You know, people tend not to bill for time or small item stuff, parts, replacements. And because of that, you're always losing money. You're sending money out the door, and you're billing for things that you're not billing for things that you're putting time and effort into, or that costs you money. And so it's always going to affect your bottom line in that way. So we're actually working on looking into expanding athletic trainers into that field to, again, fill time, to make, if off the shelf isn't as busy as it needs to be, or it's still building and upcoming, the athletic trainer could still give back to the clinic in a positive way to make a positive effect on, you know, your bottom line and your reimbursement and your time and your investment into them. So we're looking at that to see how that goes and where we may go with that in the future. And again, you can look at part-time versus full-time. So the whole reason why I brought up Play Safe in that secondary school setting of outsourcing is, you know, as a small clinic or a private clinic or as a big hospital, you may not have a need for a full-time athletic trainer in your clinic like we do here. We found that over time, as everything increased and clinics increased, we needed full-time athletic trainers. All of our athletic trainers are strictly in O&P here at UCSF. However, you may not, for a multitude of different reasons. So you can look to partner with local high schools, with local secondary schools, and split salary, split time, split benefits, and you're splitting your overall cost, which allows you to benefit from having an athletic trainer in your clinic, but not eat up all your bottom line, not eat up all your money that you may have, or you just don't have the money for a full-time, a one FTE. And then billing for AT services is always what we're looking to do in the future. So athletic trainers have NPIs. Technically, we could attempt to bill. However, California, unfortunately, is holding the rest of the country back with that. Is California does not regulate athletic trainers, and it's the only state not to do so. Once California gets on board and realizes that they need to do that and that happens, the idea is in the future that athletic trainers, for when we are running these ACT clinics, when we are doing rehabbing clinics, that time will be billable to insurance, and that's something that we can get reimbursed for to justify using that time in clinic and using that athletic trainer's time maybe away from something else like fitting OTS. So that's always in the future. That's more farther in the future. That's not something that's going to happen anytime now, but we're hoping in 5 years is kind of our goal on that we're able to take that time and actually have full rehab clinics. That'll be built into our templates of services that's just part of what we do. We have a facility for it. We have the time for it. We have the athletic trainers for it, and really provide that next level care that I think is truly lacking in O&P, and that could always, be better. And then again, create a standard of care for post-prosthetic delivery. Most people don't just want to be able to walk. Most people just don't want to be able to do ADLs. Most people want to do more, especially when you look at the comorbidity rates of amputees and how it increases significantly, and it tends to do with lack of ability to exercise and stay healthy. And so we want to create as a standard of care, not a model of care at that point, all across the nation, to say that this is what you have to do if you're going to be fitting prostheses. This is what you have to do if you're going to be performing amputations. This is the program they need to go through. We want to use research to really validate these rehab programs. There's multiple things I want to concentrate on that we're talking about. One is just with general rehab and reducing energy expenditure. The other is to test proprioception and things of that nature to reduce fall risk. If you can reduce other injuries or falls, a lot of times insurances listen, and that's what we're really looking to concentrate on. So using our Human Performance Center here or partnering with other places would be ideal, and really creating this standard of care to validate it through research. And then bill for our services. Like I said, hopefully at some point in time, athletic trainers are able to bill insurances for their services as healthcare providers. Again, it's farther down the road than I'd like it to be, but it's not an impossible goal. And again, that creates another avenue of revenue for your clinics and for your hospitals or small businesses. And then obviously, again, create that care model that goes beyond ADLs. ADLs are great. Being able to function in your daily living is wonderful, but it's not enough, and it shouldn't be enough, especially with today's day and age where activity and exercise and fitness are on the forefront of a lot of discussion, especially in children and young adults. And so we want to create that model that goes beyond. And I think that needs to be standard, not extra. And then I left some time so that we can answer any questions we may have on this.
So you guys are welcome to use the chat function if you'd like to ask questions there. You can also unmute yourself, I believe. If you need help with that, I'm happy to help do that. So we could just use the chat function to start there. All right, I don't see anything coming through. So what I'll do is I'll make sure that, oh, looks like maybe Jennifer has a question. Let me see if I can get All right, Jennifer, you're unmuted.
Hi, it's actually Mike.
Oh, sorry, Mike.
Mike is, I'm actually under Jennifer's login. She's probably listening too. But
Okay.
so, Tim, can you? Last time I heard, I was at the technology conference in the spring, and
Yes.
heard you talk about some of the. I think you described it as level 4 rehab that was in your scope within of. Is that? Am I getting that right? Is it level 4? Is that what it was?
Yeah, stage 4, level 4, whatever you want to call it. Yeah, rehab usually goes through stages 1 through 4 is considered the way they measure it.
So can you expand on what that is, or maybe give some examples of what that is, and then does that play into some of the post-fitting rehab you talked about?
Yeah, so stage 4 rehab, when you get to that level, that's usually high-level return to a specific activity. So stage 1 is range of motion and strength. Stage 2 is general function. Like I said, ADL is just general ambulation is the way to think of it. Stage 3 is more explosive work. So you're working on being able to explode out of what you're doing or be able to cut, turn, change direction, all those different things. So that's kind of stage 3. And then stage 4 is you pick a specific activity and the rehab is going to be tailored towards that specific activity. So one would say, let's say basketball. So a patient, liked to play basketball prior to their amputation. They want to get back to basketball. So that stage 4 rehab is going to actually be taking that patient onto a court and doing basketball specific drilling, exercise, and strengthening, things that really go straight to that. Or if they rock climb, we're going to work on those types of muscles and activities. And so, yes, the idea is to do things like that. We do that in very small doses now. We put on a basketball clinic, actually, as an example, every year to expose people to different drills and things they can do to kind of return to that activity. We do like the rock climbing activity, like I said. And so we can focus on what you need to accomplish within those activities is what stage 4 is. And the idea is that you could do it in 2 different ways, whether it's on a one-to-one basis and it's just the athletic trainer working with a specific patient, doing their specific activity and finding the time and, justification for that. Or it could be in a group setting where you have, 10 people that all want to play basketball. And so we put on a basketball clinic and rehab them in that manner, where a lot of them are going to be lacking in similar ways. So we're going to address it as more of a group setting. So there's 2 different ways to handle stage 4, but that's what stage 4 is. And the examples of stage 4 is this specific activity and how do we rehab you to attain that specific activity. The positive is what we would hope is that the athletic trainer, or if you had a prosthetist there with you, would be on site and we'd be making adjustments as we're doing those drills to see how can we accomplish you, being able to do this type of activity, or the athletic trainer going back to that clinician being like, hey, at your follow-up with so-and-so, this is what we had trouble doing, and we think it was a socket fit, we think it was a foot adjustment, we think it was a knee center issue. And how do we adjust those things to get them to do that? So you can kind of relay the information in different ways, but it affects it in more than one way. It's both the athletic trainer rehabbing the muscles that are lacking, but also reporting back to the prosthetist to say, hey, we need to adjust these things so that they can do this type of activity.
Okay, that makes sense. And I guess because it's activity specific, you're not really stepping on toes of, say, physical therapists, because it's related directly to an activity and not a body part. Is that?
In general, we're not stepping on toes of athletic or physical therapists anyway. So the general rule with most insurances, the large majority, including Medicare, is once a patient's able to ambulate with ADLs, insurance doesn't pay for any more physical therapy. So the problem is even though physical therapists are educated to an extent in most of this, one, I think athletic trainers are more experts in that stage 3, 4 rehab. That's what we deal with on a more daily basis in our education and our upbringing per se. But 2, PTs can't bill for it, so they don't do it. And so if you can't bill for it, you can't go to PT for the most part, unless you have a lot of money to pay out of pocket for it. So there isn't a lot of toe stepping. Plus, in general, athletic trainers tend to work with PTs great. And mainly because, say you can go to PT for this. Well, usually you can only go to PT once, maybe twice a week at most. So on the other 2 days, maybe you see your athletic trainer, or one other day that week, you see your athletic trainer in clinic, and you're able to continue that care or give extra care. So it tends to be more of a collaboration. There's always some overlap, But as long as you have good communication between your physical therapist and your athletic trainer, a lot of times you're both trying to accomplish that same thing, and nobody really gets upset. We're not taking any money out of their pocket, and they're not affecting us in any way either. We're both just trying to collaborate and really provide the optimal care for the patient.
Okay, that makes sense. Thanks.
Yeah. Anything else?
Okay, well, I think that's it. Hey, Tim, thank you so much. That was fantastic. Really appreciate it. Again,
sorry.
Yeah, go for it.
Okay, I'm sorry. I thought there was gonna be another question. I'm gonna ask you one more question while I've got you here.
Yeah, ask away, please.
So the other thing, in Vancouver, ABC had talked a little bit about privileging. Do you know much about that in terms of COs or CPOs privileging?
Yep.
Okay. So,
go ahead.
Go ahead.
Sorry.
Your thoughts on that? Have you guys done that? How do you document it? Because I think that my impression from that is the next logical progression. So once an ATC has fitter certification or assistant certification, to me it makes sense that a CPO would then say, you've proven that you're able to do these things, and here's how you're truly an extension of the practice. So I just want to know if you guys have done that, how you do it, how you document it, that kind of stuff.
Yeah, absolutely. So we actually privilege all of our athletic trainers when they're hired, mainly as part of their observation to show that a lot of times, again, you need that 500 hours of observation, but because of our education, we don't need 500 hours to know how to fit a brace and understand the patient's anatomy and that type of stuff. So we'll privilege our athletic trainers prior to getting their CFO while they're doing their observation time to allow them to start to see patients similar to a resident, where they'll go in, do the majority of the work with the clinicians there, and then the clinicians will co-sign on their drop charges and their notes. So we usually privilege early. And then I do believe it's a form that our compliance manager fills out to say that they are privileged and turns it into ABC or documents it in our own personal things in case ABC ever came back to say, hey, what is this kind of thing? And then we do minor stuff. Like I said, for technical work and things like that, we will privilege our athletic trainers to allow them to do minor adjustments and things of that nature on site that, again, the CP or CPO or CO is comfortable making those adjustments or understanding that. So we do actually privilege all of our athletic trainers, but we do it right away. We just do it when they come in because, again, really the education we're giving our athletic trainers is just the basic braces, not anatomy, rehab, or any of those things that we want them to be involved in. And then we just have it documented in our own systems and then turn it into ABC as needed or if requested. And we've never had an issue with it. We've never had ABC come back. I think because they recognize us as allied healthcare professionals, there's a lot less stringency towards it. Whereas if it was just somebody off the street that has maybe a kinesiology background, but not medical background or healthcare background, ABC doesn't seem to be as diligent about looking into being like, I don't know what you're doing. I think they have a good idea of what we do and they kind of respect it.
Sure. It makes sense. All right. Thank you.
Yeah. Thank you very much, guys. And yes, please feel free to reach out with any questions, concerns, or things you think of later.